Hi, welcome to today's Leaders in Mental Wellness and Diabetes, where you will hear insights from the top minds in the world of diabetes care. Hosted by Dr. Char.
I like a two-way conversation.
Hello, how are you today?
Hello, Dr. Char. I'm fine, thank you.
I would like to introduce to you guys today Dr. Shagun Bindlish. I've worked on pronouncing that name. She is an internal medicine physician who is using technology and medicine to bridge a gap for patients who deal with diabetes. Welcome to the podcast. I am so honored to meet you.
Same here, and I'm very, very excited to meet you as well as your team.
Wonderful.
And I'm very thrilled to be here.
Oh, it's an honor to have you. I have a lot of things I want to ask you. I have written down that you're a board member for the American Diabetes Association. You work in obesity medicine. You're a wellness coach. That's just to name a few. That's the few that we could talk about all day. But first, how did you get into helping patients with diabetes? Do you deal with diabetes yourself?
No, I don't. Fortunately, but I grew up seeing my parents struggling with type 2 diabetes. However, it did not ring the bell so much to me because I was not aware what is that. They were taking the medicine and I just knew that they have some problem ongoing, but I never understood the complexity of the disease. Mm-hmm. But I would like to step back and tell you one very important thing which I feel about the diabetes. So people living with diabetes, no matter what age group they are, they need three constant words in their life. That is connection, compassion, and hope for cure. And to sustain this goal, they need perseverance. So it's what brings them together, keep their hearts full, and shapes them into people they are. So my journey to diabetes care started when I made my first connection with 25-year-old patient with type 1 diabetes who was admitted to the hospital where I was doing residency training, and she was pregnant. I thought this was the most challenging thing, having a pregnancy, type 1 diabetes, sure. Plus she was admitted in the hospital. And at that time, it was very hard for me to understand how fluctuation of blood sugars can be so overwhelming during the pregnancy, looking at her condition. While taking care of her, I was able to see very closely how she was going through emotional roller coaster every day. She was very frustrated, worried about her child, and at the same time, she was looking for a lot of support.
Sure.
Which was very hard to give during the hospital setting. Then I realized a diabetes diagnosis can feel like not just a threat to the health, it can also seem like a threat to a person's way of life, because managing diabetes means making changes to your day-to-day life. Yeah. So after that, I somehow decided that I want to dig it more. I want to put a microscope on this disease and want to learn what else is going on around this world. What are the complexities of the disease? And at that time, I understood the fact that this can affect any age group, as small as like child who is born with diabetes and going to live it forever, or somebody who is going to get it at any age of their life.
Absolutely.
So I pursued the fellowship training in diabetes in Ohio University, and it was a one-year training program, which was just focused on diabetes. And I was so glad to get into it. And it helped me to dive deeper in this world since I was already very curious growing up, looking at my parents. So from joining the diabetes fellowship program to pursuing certification in lifestyle medicine, this journey has been so incredible. So with my extensive growth in this domain in multiple settings, I have had experience in noticing the huge gap and challenges that exist today in our system.
Yes. Oh my. And I'm going to jump ahead. I just can't help it. What is the biggest gap? What do you see as the biggest gap today?
So today, especially this year, after the global pandemic, we have unfolded so many new chapters around the diabetes and the other chronic disease. And the impact is so large that when it comes to diabetes, with economic crisis, unemployment, civil unrest, mental health issue, I think mental health issue is a major gap where we are not able to connect the dots together.
Oh, You understand that just scratches every itch I have right there because of the years of experience I've had coming up in rural America. I didn't even know there were hospitals hardly to even house people with mental illness, much less teaching people and people being concerned about their mental health and knowing how to take care of it. And today, to know there is a you that is trying to connect my mental health with my dealing with type 1 diabetes, that makes tears come to my eyes. That is wonderful. How big is our community? How much help is there out there? And what are you doing to make that all come together?
So what I understood with so many years of experience is that diabetes and depression has a bi-directional relationship. In fact, when I was doing fellowship training, there was a study done on Appalachian population, and they found that there is a huge, high incidence of depression in the patients with diabetes. And it was also other way, people who were having depression were more commonly getting the diabetes. So I really wanted to tell here that diabetes distress is real, and it occurs because virtually all diabetes care involves around the self-management behavior. So it does, and we all have to understand that diabetes does not take a break, and demands are not only continuous, but often unpleasant, as well as whether they are the shots, finger sticks, or lifestyle changes. And I think you have gone through yourself and you know it, how it is.
Absolutely.
But the perseverance is in self-care is the major key, I think. So what I have started doing is education. I think that is the most powerful tool, and that's my mission always. Since I joined the hands with American Diabetes Association, I'm also trying to focus more on diabetes in primary and trying to help our frontline physicians. They are primary care physicians, to help and address this disease and have like a multidisciplinary approach. So my ultimate goal is to introduce, in American Diabetes Association actually has a very good handout where it says how it's very important to have a coordinated care, and how that should be like having a dietitian in the team, having a mental health practitioner in the team, having like a physical exercise trainer. We should have an IT in the team. We should have like a multidisciplinary team, because we can't do it alone. We need everyone together. Right. So that is what I try to, this is my initial steps and trying to bring to address and tell people or practices to have that multidisciplinary approach and address each and everything. But you know how the setting is right now. Physicians are not able to spend enough time with the patient. There is follow-up has been a challenge. So we do miss so many of these darts because patient loses hope. I feel that patient with diabetes needs support all the time, not like once in 6 months.
Right.
So somebody who can follow up with them more frequently. I really feel that one day I can develop an app so that people can connect with their physicians all the time, or ask their questions and share their challenges, share their emotions. But that is all vision, which is where I'm working through.
Well, one of the things that I've noticed being in the emotional side of things, and I think emotions are a wonderful tool, but they are poor leaders. So in the beginning of the diagnosis of diabetes, if we could be parallel with a doctor's appointment, not 6 months later, once we notice there's depression, but if we could be parallel and start understanding what our emotions are good and what they're meant for, and that we can be the boss of them. If we could learn that alongside the physician who's treating with the insulin or the meds, and the nutrition specialist and the educator, we all are educators. That's what doctor means to start with, right? Teacher. So my goal is to have mental health raised to that point of not waiting until it's mental illness, but working alongside a patient to learn what mental health you have and work with that, and hopefully prevent it from going to mental illness. And then when it is mental illness, there we are again. There we can help in that as well. What's your opinion of that? Starting the mental health piece a little earlier than we've been doing. Is that innovative thinking, or is that already on the horizon?
No, this is such an important point that you have brought, and I'm so glad. I think like we have like a diabetes screening and the quality care, depression is not part of it. So I feel that depression questionnaire should be a part of that essential tool, which should be addressed every 6 months, and I don't think it's even there right now. So we do have to ask patient about how are they going through. And even I would like to give you an example. I interviewed a patient who had a gestational diabetes, and I asked her, how was your first meeting with dietitian? And you won't believe she started crying because that appointment was so overwhelming, because all the focus was to give her the meter, give her full packet of blood glucose monitoring sheets, and giving her multiple diet sheets. But nobody asked her how is she feeling. This was a mom from Asian ethnicity, and she didn't have any concept of having a diabetes as a diagnosis. And first thing we also bring up is that you may be on insulin. So that was even more heartbreaking for her. And she was crying for so long. And to understand this all emotions, it took her a long time to heal from that. So she took it as a traumatic event instead. She did quite well with the diet management. But I thought that at that time, when we are introducing patient to this diagnosis, we really need that mental piece, mental health support piece, so that they understand the complexity of the disease. But at the same time, they also understand that you with this proper self-care strategies and proper management and proper understanding, they may not be going towards all of the complexity of the disease. It's all preventable.
Yes.
So I really feel that we definitely miss that piece.
Well, I think maybe in Tennessee, I was one of the first, if not I don't know of any other in my field that was down the hall from an endocrinologist doing behavioral health. I think I was at least in the beginning, because I'm old as dirt. And so knowing that we were pushing doors open to provide that care, and physicians years ago, a specialist said to me, I would love for my patients to see you, but I don't want them to think I am thinking they're crazy. That was his terminology, because of how it was viewed. And so he trusted me enough to tell me, and I'm glad that he did. And you were talking about the nutrition specialist giving them all this data. They are timed. They don't have much time. Everything's based on how much insurance is paying, and we've got to get through all the information. It's almost sad for all of us, the patient and the specialist, because we all want to do good for them, but we have restrictions based on, so we need to push more doors open. I think my point is to say we need to keep pushing. And exactly. I think that's what we're all in this for. And I think a good Southern belle wants everybody to like us. And I think that's important, but it's also important we can smile while we push those doors open, because the patient that comes in and receives trauma from the diagnosis, the specialists that are in their field doing their part can't be held accountable for that. But if we can embrace each other and they can embrace the mental health piece, we can help them swallow all the understanding that they're giving them, the education on the pump, the education on the needles, the education on the food. We can help them swallow that easier and not walk away with PTSD, for God's sake, to deal with. And then that leads me into a segue to say, we have so many patients with diabetes now that there's many, many, many more coming to the doctor, and they're overwhelmed with all they have to do. And we have to treat them. So now my segue is, you deal with obesity as well, right? How do you help a patient who walks into an office, gets this gets this diagnosis that even if parents had it, you're proof that you don't always understand it. You don't always have this great knowledge. And people are just now being able to Google everything. And now we get too much information. Now we don't get all the accurate information. But how do we walk in, get that diagnosis, and learn, already know we're overweight, but learn now every bite that goes in my mouth, I have to monitor. I understand there's 119 opportunities to eat a day, and I want to take all of them. And I know everybody does. How do you help with the obesity crisis right now without adding to the patients being overwhelmed with the diagnosis?
Such an important and sensitive piece that you have brought in today. And I'm so glad that we are discussing this. So, and that was my motivation too. So have you heard about the weight bias?
No.
There is a concept about, and which we are, as a Obesity Medicine Association member, I'm trying to learn, and I have understood that patients who come to the office has already failed their medication treatment, not medication, their own self-care strategies of using a diet, lifestyle, and there is so much of shame and guilt when they come to you. So because they have all the blame in them, they think that they are the wrong thing. Because so far we always had that notion that says calorie in and calorie out, like more you exercise, more you eat, more you exercise, otherwise you are obese. But that's not true. So initially when they come, it's very, very important to address that issue, that we have to take that burden of blame from them and then understand and put that epigenetics piece. Because with epigenetics, it's very important that that's an imbalance. You might have the genes, but the trigger is environment. So it's so important for us to know that this balance is not dependent on them. It's the situation. There is a lot of background which we don't know. So and addressing the weight bias has helped me so much. I asked them what they did so far, what has worked for them, why do they think that they failed, and what made them what are their common challenges that they are facing into day-to-day life. So first, to understand their perspective and challenges, that really helps. And because until and unless we address that, we cannot address the treatment. So I feel that, like you said in the beginning about motivation. So we have to start with that. We have to give them a hope that there is a hope for cure. And we have to give them the motivational interview or motivational piece and the support, a lot of support. So that's the way I try to start with always.
Awesome. I have so much. We could talk for 3 days, and I'm trying to keep this at 30 minutes, but we could talk on and on and on. But when we talk about obesity, we talk about their self-care. We talk about the piece of mental health as well as mental illness. We talk about whether it's one visit 6 months or one visit 3 months. Sometimes we're fortunate to get in every 3 months because insurance requires it. And sometimes that's all we get.
Mm-hmm.
And my love, of course, is the side of the emotions and how you balance that, because I believe if you balance that, everything you need to do comes into an ability to accomplish it. And then you can live with peace and joy and vibrancy. And that's the goal, after all, that we want to help people do, right? We don't want it to be a constant struggle.
Mm-hmm.
We want it to be a good life.
Exactly.
What would you say to somebody? I don't like to call it advice, but if you could tell the people who listen to me, I want to bring people who know more than me, who know outside of what I know, who can better help, or who can be a team with me to help. So anybody that would be listening to me today, what would you like for them to know that they could start today and do to help themselves?
I have so much to say, but I know we have to keep it
It's
short.
okay. You just go right ahead. You go right ahead. We'll go over. They'll cut it out what they don't want.
So what I feel that very, very important is to understand the self-care strategies. And it was very interesting to read in one of the articles in American Diabetes Association's journal, which is called Diabetes Spectrum, about a diagnosis called diabetes overwhelmus, which was very interesting. And I like that word because that's what is happening. It strikes when a person's stress level is so high that coping mechanisms break down. So best way to deal with the situation is to be specific. And this is for primary care physicians who are going to address and meet their patients. And even for the patients, they have to be specific about what they're going through. They have to be open and identify the problem, because that's where we are able to help them to get unstuck from their
Yes.
like web. We are able to untangle the web and then make a plan for change. So we have to identify those things that fit in lifestyle. This also goes with obesity management, and that makes us very easier to reach the goal. Then experiment. No plan ever works perfectly. So don't lose hope. People who sees diabetes management, they have to see it as a series of experiment and living well and generally succeeding in living well, right? And then family and social support is very, very important because it's a family disease. One person in the family who has diabetes, it impacts everybody. So, and there are a lot of overwhelming emotions involved. So until and unless there is a support, we cannot win this battle. And then nourishing emotional coping skills, and that's why I kept it last, because that's where you can add your final touch to it. And I also think is that humor and diabetes may seem an odd combination. However, it can be a very helpful coping skill for the patient. And it reminds me of my patient whom I loved, and I can never forget. This was right after my fellowship. I took over endocrinology practice, and this lady, 45-year-old, walked in my clinic, and first sentence, and she had an amputation of her toes. And her first sentence was, "Do you see, I'm going to save money on the pedicures." I just couldn't believe she said that. I was so shocked when I saw her, first of all, and the attitude and approach that she had was amazing. So I really feel that these are all the pieces. These are the 5 tips which I always try to tell my patients and also the providers. It's very, very important for us to have and make sure that they understand.
Well, I am so thankful, so grateful that the emotional piece is a part of it, of course, because that's my love. But if you have touched the heartstrings of anybody else like you have mine today, and they want to know how to make a plan for change, how does somebody find you? Can you tell us? I'm sure everybody's looked at LinkedIn like I have, but let's rehearse that for them. Tell me the places you are and the things you do so that people can learn. And if not you, where do you send them to make this plan for change?
So I'm working to get my own website going, so that I will be posting that on LinkedIn soon. But you can reach me at my email. It's sb@shagunmd. That is currently I only have that way to connect with people. Soon, once my website will be running, it will be easier for me to connect through that. I'll be posting more on that one. I also write the blogs, so I'll keep that going. So it will all be on my website. So I think best way right now is the email, and then I can help them and understand how to make the decision where to go, depending on what are their needs actually. So
and if they didn't write the email down, they can find that on LinkedIn, right?
Yeah.
So LinkedIn is the source right now that we follow and watch for blogs, watch for a website. We watch for more that comes from you. And specifically, you can help people learn how to make a plan, where to go to get that. Are you by chance in private practice as well?
Oh, yeah. I work for One Medical in Bay Area in California. So I work for One Medical. So if they want to come through One Medical and see me in the clinic, then that's another way. We are doing the remote visits, but this is my passion and this is very personal. So I am happy to help anybody and if it is a healthcare professional, if they need any guidance, how to work with the complex patients or how to address this emotional piece for the patients or anything, they can reach me out. And I'm also having a Facebook page called Diversity. Let's break the bond together. They can connect me via Facebook as well.
Spell diabesity.
Yeah, DIABESITY. Diversity.
And that's all they have to type in. And that's on Facebook?
Yeah, that's on Facebook. Yeah.
Facebook. I'm going to go make friends today, and I hope everybody else will as well. Let's be a community. Guys, let's be friends. Let's be one in this cause. And if this happens to be one of those audio podcasts, then you're not going to see these dots connecting behind this beautiful lady. But the goal and the dream of connecting the dots with this mural behind you says it all. And that's what my desire is. And I bet every other patient and professional. So let's go forward with hand in hand. Well, 6 feet apart. I don't know how we're going hand in hand, but we're going to do this together, and we're going to make the world of patients who deals with diabetes a better place and help them be better served and to serve themselves better. Ooh, we should make a statement out of that right there.
And remember, connection, compassion, and hope for cure.
Hope for cure. I love it. Thank you so much for joining me today.
Thank you very much for inviting me. It was my pleasure being here.
It is great to have you. And my trust is that this is not the last time I'm going to talk to you or see you. And I hope everybody feels the same, and we'll all connect up. We could all go see you in California, and now remotely we could get an appointment online, I bet.
Yeah, sure.
Thank you so much.
You're welcome. I'll be in touch with you through email.
Yes. Let's be in touch.
All right.
Bye.
Bye.